because a lot of what I will be covering has been covered already. And I'm going to be talking about the chromosomal anomalies that are associated with congenital heart disorders. I thought instead of going through, because I wasn't sure how many pediatricians would be here, I wasn't sure how many, I assumed I was going to be talking to a group of pediatricians, but actually there are a lot of fetal doctors here. So it's an obstetrician's and a fetal medicine's point of view. A lot of what I say has already been covered, so it's just a repetition and a reiteration, if you like. So we screen babies for congenital abnormalities. We've heard about it. It is the commonest anomaly we see, the heart. And we can see a lot of them prenatally. It's increased association with neurodevelopmental outcomes because of either chromosomes or genetics, means that it is something that we need to know about before delivery. We've heard already about the first trimester screening, and so as an obstetrician we have certain screens that we do, and that CART screen starts in the first trimester. It starts with the nuchal translucency. We've heard a wonderful presentation by Dr. Ann about the association of increased nuchal translucency and heart disorders. And yes, if it is over 3.5, the recommendation is for a fetal echo to be done in that baby. We also heard about, very elegantly today, the ductus venosus, the tricuspid regurgitation. So there's certain markers that increase the chance of the baby potentially having a cardiac abnormality. So this is also done in the first trimester. We do a blood test, a genetic blood test called cell-free DNA or prenatal screening for chromosomal abnormality. But going back to the heart now, the second bit of the screening happens in the second trimester. So again, we've heard Dr. Leanne spoke about all the different associations of abnormalities that can happen with different conditions, and we of course are looking particularly at the fetal heart. Again, we've heard how we actually look at the fetal heart in a little bit more detail, from the 4-chamber view to the outflow tracts to the 3-vessel view. Detection rates are great if we include the outflow tract views, as Dr. Salaman has mentioned before. So this is part of standard screening that we do for all babies. Now, so we found a heart condition. As an obstetrician, it is important to have a multidisciplinary input, and the reason is there are other issues going on. Does the baby have any other abnormality? Could this be part of a syndrome? Is there a genetic predisposition? Is there consanguinity? So there's lots of different things that need to be looked at. We're fortunate in having a pediatric cardiologist. Dr. Mohammed is part of the team at King's. So whenever we have any suspected cardiology or cardiac abnormalities, we refer on for a fetal echo, and of course our neonatologist involvement in the care. And the aim is to inform patients of the diagnosis. It's not that we can do a lot prenatally. There's very little things that we can do prenatally in a cardiac abnormality. The main thing is the rhythm disorders that we see, but other than that, it's really about planning management in terms of delivery. It's in 20 to 40% of cases, it is seen. Again, the prevalence varies depending on what series you look at. If you look at stillbirths versus live borns versus just screening fetuses in the mid-trimester. When we see a baby with a cardiac abnormality, we always talk about genetic testing. And depending on when it is, hardly see it at 12 weeks. So we talk about an amniocentesis. Half of babies, or a third of babies, have aneuploidies, out of the half that have abnormal chromosomes. Now, the frequency of that, again, depends on whether we see the baby antenatally. The pediatricians out there will be seeing a lot lower incidences, but we see a lot that don't make pregnancy. For example, trisomy 9s and 16s have an intrauterine lethality rate. And then we talk about 22q deletion. Of course, that's also been spoken about. Now, we have a rough idea of what chromosome we're talking about, or the chance of a chromosomal abnormality based on what the abnormality is. So again, Dr. Leanne has gone through this whole slide. Certain, for example, transposition, very, very, very small, if not zero risk of chromosomal abnormality, as opposed to something like an AVSD, which is a much higher chromosomal abnormality. Regardless of that, we always talk about chromosomes, we always talk about genetics, and we always talk about amniocentesis with a baby with an abnormal heart. Again, a list of something that's already been covered, so just skimming through this. The three common chromosomal abnormalities that we find are trisomy 21, 13, and 18. They all have their sort of specific cardiac abnormalities that we see. And then, of course, there's Turner syndrome, a sex aneuploidy, which has also a particular group of conditions in terms of abnormalities in the heart. DiGeorge syndrome, also mentioned. So 22q deletion is something that we always look for in a baby that has a cardiac abnormality, and Williams syndrome as well. Williams is a genetic mutation, not always looked at, but if we do a microarray, we will be looking at that. We talked about VACTRL as a group of association. Now, there's lists and lists of genetic abnormalities that are associated with cardiac abnormalities. Hence the importance of getting a geneticist involved with certain conditions, particularly if you see little soft markers, micronathia, a cleft palate, certain subtle features if you think might be increasing the risk of a gene disorder, and certainly if there is a previous history or consanguinity, this might be looked at. So there's a group of autosomal dominant conditions, autosomal recessive, single gene X-linked inherited disorders, as well as mutations that are non-syndromic. So what we do is we do an amniocentesis, and we look at two things. We look at the karyotype. As I said, the commonest chromosomes are the ones that we talked about, and the XY. So karyotype for as well as fish. Microarray. Microarray is a little bit controversial. It's very costly to do a microarray, particularly if it's a genetic screen and insurance is not covering. So it's something that we not always routinely do, but it's something that we discuss with the couple. And the problem with microarray is not all, if the mutation is a balanced mutation, it is not detected, and that's just the way it is run. And sometimes we find certain things and we don't know what it means. So there's a little bit of controversy about microarray in chromosomal analysis. What do we do then? We follow up the baby. We look for heart failure, we look for rhythm disorders depending on the abnormality, and we do that regularly with ultrasound. There's very little that we can do in terms of treatment of a cardiac abnormality other than a rhythm disorder. So sometimes we do need to manage SVTs that are not reverting or showing signs of heart failure by giving maternal digoxin. And then cardiac intervention, not something that we do still very much in the investigation and research arena. Delivery planning is important. We need to make sure that we have the appropriate team ready. We very recently had a baby with a cardiac abnormality that was delivered at King's with Dr. Mohammed, who prenatally counseled the patient. Neonatologist accepted the patient, stabilized, and soon after transferred the baby to a tertiary level cardiac surgery unit for surgery. So that required a little bit of planning, which can be done despite insurance issues that we have. And cesarean section is not something we do for a pure cardiac abnormality, unless there's an indication for it. So to summarize, again, a lot of this has been discussed before. We find a lot of the heart disease that you guys see out there, the pediatricians out there, actually can be seen prenatally. And we do this by the first trimester screening as well as the second trimester screening. Genetic abnormalities are common when you see a heart condition. And we always talk about karyotyping and plus-minus microarray for genetics. It depends, frequency of the chromosomal abnormality depends on the malformation that we see. And as I said, the importance of having a multidisciplinary team to manage these cases. Thank you very much.